Such a great question. I want to talk about the NICU levels, resourcing, what NICU transport networks look like today across the world, and the continued advocacy to improve access to care and making sure that people get the care that they need when they need it, where they need it. So there are 4 different levels of NICUs. Level 1 and level 2 are really basic. It's really basic care. Level 1 is like a basic newborn care. It's not even really considered a NICU. It's healthy full-term babies, quick evaluation. Level 2, a lot of these community hospitals will have a level 2 special care nursery. Some preemies can stay there. Anyone over 32 weeks that might just need a little extra support for maybe a couple days or a week, but they're not needing like intensive care like you would see in a level 3 or level 4. Level 3 and level 4 are tertiary care centers. Level 4 are definitely at children's hospitals. Level 3 can be at a children's hospital or a standalone hospital. And it really depends on the type of care offered, the resourcing, the staffing ratios that they have, the training of said staff to be able to do the complex procedures, treatments, therapies, etc. that are required of the most complex babies, the earliest babies, the sickest babies. Those with very complex medical conditions end up at level 3 and level 4 NICUs. So again, it is not feasible to have cooling at all NICUs and community hospitals and all the things because of the staff that is needed, the training that's needed for that staff. Cooling blankets are really not the issue. Cooling blankets are not a high ticket item. That's, the costs have come down significantly. What is newer that we're seeing a lot more implementation of are the passive cooling systems or the other neonatal cooling transport systems that are available out there right now. So this is a infographic that I pulled off of the internet, but basically what the mobile pods look like for these babies. There are different systems of cooling transport systems that are available, and a lot of places do have them. Those are more expensive to get into practice. It's really more of a community effort to fund those and get the training and all that. For a lot of the level 3 and level 4 NICUs, they have an activation team that will come and get babies if they are at a community hospital. That was the case in my situation and many others where the actual NICU team is coming to get your baby. This is a trial that was published from Australia called the CoolCot trial, and they were in comparing different systems of cooling blankets between one specific one and ice gel pack methods. Ice gel pack would be considered passive cooling. So they're looking at, are outcomes better? Are there other metrics? Looking at these neonatal cooling devices versus the passive cooling methods that are used. And work like this really works it within existing or established transfer networks, neonatal transfer networks, which exist all over the world. This was a really great paper that you can pull up as well that talks about Maryland. They have about 800 babies a year born with HIE. It goes through all of the different metrics that they use on their setup and how they determine who needs to go where. In the United States, I will say that if you are not aware of your state level perinatal quality initiative, you should look into that and get involved. That is going to be where the focus is improving maternal and neonatal outcomes. HIE is usually a focus area that has either been worked on, continues to be, or should be. And I think, from the Hope for HIE perspective, we get involved in advocacy whenever and wherever we can. Everyone can get involved in advocacy. There are so many ways, and at the local level is especially important. So you can reach out to your perinatal quality initiative, ask questions. Where's the data? I'm curious. Where are we at with this? Find out more about what that network looks like and what typically the metrics will be like time from transport to initiation of cooling or to the center, and looking at the established networks and how many babies, were evaluated and were transferred or weren't transferred and their outcomes. So again, the disparities of access to cooling are really surrounding resourcing and not necessarily as much on the cooling blankets themselves and cooling devices themselves, but more so on the human resources, transfer networks, and that feasibility. Will level 1 and level 2 NICUs ever keep babies to cool? It's very unlikely because they do not have the resources and staff and training to actually have that happen. But can we do better with all sorts of quality improvement to get babies to cooling in more effective, efficient, and safe ways? Yes.